Let's now turn our attention to the upper limb, and what we want to accomplish in the upper limb is the following. We want to make sure we know the neuromuscular components of the upper limb, of everything that's to be found in the upper limb. For the purposes of the exam, the neuromuscular components are by far the most important. We want to use our understanding of that to understand the signs of upper limb nerve injuries and be able to identify those injuries. We want to have a brief view of the arterial supply of the upper limb, and then focus on a couple of regions of skeletal injuries in the upper limb, particularly for the shoulder and the wrist. So what we will be doing is first looking at the neuromuscular components of the upper limb. Then we'll focus on nerve injuries, then a brief look at arterial supply, and then the skeletal injuries associated with the shoulder and the wrist. So let's start with the nerve supply to the upper limb, which is from the brachial plexus. So the nerve supply for the upper limb comes from spinal cord level C5, 6, 7, 8, and T1. And what's being represented on this diagram here are the anterior rami of C5 through T1. Remember, these are not spinal nerves because only anterior rami will go to the upper limb, or to any limbs for that matter. So only anterior rami go to the limbs, posterior rami are going to the back, and so participating in the plexus will only be the anterior rami of C5 through T1. After these emerge from their intervertebral foramina, they're still in the neck, and what happens is the anterior ramus of C5 and C6 gets bundled together by connective tissue to form the upper trunk. The same thing happens for the anterior ramus of C8 and T1. They get bundled together to form the lower trunk. The anterior ramus of C7 stays by itself and just changes its name to middle trunk. So now we have three trunks. We're still in the neck. As we are passing from the neck into the axilla, as we're beginning to enter the upper limb, each one of these three trunks will divide into two branches. Those branches are called divisions, and it's an anterior division and a posterior division. So each trunk will have an anterior and a posterior, anterior and posterior, anterior and posterior division. Now, it's useful to understand why we have anterior and posterior divisions. And it goes back actually to how the limb bud forms. When the limb bud forms, it forms as an evagination from the side of the trunk in the lower neck and upper chest of the trunk as an evagination of ectoderm. That ectoderm that evaginates will become basically the skin of the upper limb. That evagination of ectoderm ends up being filled with mesoderm. And then what happens is the central core of that mesoderm, running right down the center of the limb bud, the mesoderm becomes very densely packed together. And that dense core of mesoderm is what will become the skeleton of the upper limb, humerus, radius, ulna, etc. The remainder of the mesoderm that's not so tightly packed together is mostly going to become the muscles of the upper limb. And so right from the very beginning, what we can see is that those cells that will become the muscles are either in front of or behind that central dense core. And so we see the beginnings of what will become our muscle compartments. The cells that are in front of the bony core will become the anterior compartment muscles, and the cells that are behind that dense core will become the posterior compartment muscles. And then we'll see that anterior compartment muscles will mostly become flexors of the limb, and posterior compartment muscles will mostly become extensors of the limb. Now, those cells that are going to go on to become muscles, in order for that muscle development to proceed, those cells have to be innervated. So we're going to have nerve fibers growing into the limb bud to innervate the cells that are developing into muscles. And since those cells that are becoming muscles are either on the front side or the back side of the limb bud, the axons that are growing into them have to either go to the front side or the back side of the limb. And so we still see the reflection of that in the fact that we have anterior and posterior divisions. So the anterior divisions are carrying the nerve fibers that went to the anterior side of the limb, and the posterior divisions carrying the nerve fibers that went to the posterior side of the limb. And that's true for each of the trunks. So what that tells us is any motor fiber that's in any of the three anterior divisions must be going to innervate an anterior compartment muscle. And any motor fiber that's in any of the posterior divisions must be going to innervate a posterior compartment muscle. Then, as we continue through the axilla, the anterior division from the upper trunk and the middle trunk gets bundled together into a single structure that we're going to call the lateral cord. The anterior division from the lower trunk will stay by itself, and we'll just change its name, and we'll call it the medial cord. And the posterior division from all three trunks will get bundled together by connective tissue, and we'll call that the posterior cord. So now in the axilla, we have three cords, and they're named lateral, medial, and posterior, and those names are based upon their position in the axilla relative to the artery that runs right through the center of the axilla, the axillary artery. And so the lateral cord is lateral to the artery, medial cord is medial to the artery, posterior cord is posterior to the artery. But the important point to keep in mind here is that the lateral cord and the medial cord contain only anterior division fibers, and the posterior cord contains only posterior division fibers. So the key difference between the three trunks that we find in the neck and the three cords that we find in the axilla is that the cords are segregated with anterior and posterior fibers kept together in their respective cords, whereas the trunks are mixed with anterior and posterior fibers all together in the same trunk. Then, as we continue through the axilla, and we're getting ready to leave the axilla, each of the three cords divides into two. The lateral cord divides into two. One branch will be called the musculocutaneous nerve, and the other will become part of the median nerve. The medial cord divides into two. One branch will become the ulnar nerve, and the other will become the remainder of the median nerve. And the posterior cord divides into two. One branch is the axillary nerve, the other is the radial nerve. So now we have 5 terminal nerves, musculocutaneous, median, and ulnar, which contain only anterior division fibers, and axillary and radial, which contain only posterior division fibers. So those are going to be our 5 terminal nerves, and we'll take a closer look at them in just a few moments. But notice that in addition to those 5 terminal nerves, we have lots of other branches that came off along the way. Those as a group are called collateral nerves, And rather than worry about each individual collateral nerve, just if we understand why we have collateral nerves, that will really be useful. The point is that these 5 terminal nerves aren't formed until we're leaving the axilla and entering the arm. By the time we get that far out into the limb, we've already passed muscles that are more proximal, the muscles right around the shoulder and the muscles that form the walls of the axilla. Those muscles need to be innervated. These nerves form too late to innervate them. And so what we do is we take branches off along the way to innervate those very proximal muscles, so as we're passing them, we can send branches into those muscles to innervate them. So the common thread among collateral nerves is that they innervate very proximal muscles. And if we look at this chart that shows the collateral nerves, sure enough, you look at what muscles they innervate, and they're the very proximal muscles around the shoulder and the axilla, right? Whereas the 5 terminal nerves are going to innervate the muscles further distal, in other words, the muscles of the arm, forearm, and hand. So now let's look at the terminal nerves. We'll start with the anterior division nerves, musculocutaneous, median, and ulnar. So we have 3 anterior division nerves. We have three anterior compartments in the upper limb: an anterior compartment of the arm, an anterior compartment of the forearm, and an anterior compartment of the hand. So we have three anterior division nerves, three anterior compartments of muscles. So this probably will be fairly easy, right? Let's take a look. First, we have the musculocutaneous nerve. So the musculocutaneous nerve innervates all of the anterior compartment muscles of the arm. That's it. All of it. So we're finished with the musculocutaneous nerve, and we're finished with the anterior compartment of the arm. Now, it's useful to realize that the muscles that are in the same compartment more or less have the same function. So these anterior arm muscles are, for the most part, elbow flexors. That's really the useful way to do this. You don't want to try to learn this muscle by muscle by muscle, and for each muscle learn the innervation and learn the function. Because clinically, if a nerve is lesioned, all the muscles innervated by that nerve are going to be affected, and all those muscles are going to pretty much have the same function. So the clinical presentation that you would see would be a patient with some functional loss, and you're going to be asked about what nerve might be injured. So the functional loss will be associated with a group of muscles, and that group of muscles will be innervated by the same nerve. So that's really the way to approach it, not muscle by muscle. Okay, so that's the musculocutaneous nerve. The median nerve. The median nerve does almost all of the muscles of the anterior forearm. Almost all the muscles of the anterior forearm, but almost means there's some exceptions, and there are 1.5 exceptions. 1.5 exceptions. We'll come to those exceptions in just a moment, but the muscles of the anterior compartment, for the most part, share a function, and their function will be flexion of the wrist and flexion of the digits. Okay, so they're wrist and digit flexors, anterior compartment muscles. Now, they're all going to be innervated by the median nerve except for 1.5. But realize that the nerve that 1.5 muscles that are the exceptions, what that has to be innervated by must be the ulnar nerve. If it's not the median, it must be ulnar, because it still has to be an anterior division nerve, because it's an anterior compartment muscle. And since we said we're finished with the musculocutaneous, if it's not median, the only other choice is ulnar. So the 1.5 exceptions will be innervated by the ulnar nerve. So rather than learning all the muscles that are innervated by the median, just learn the 1.5 exceptions, and you'll know everything else is median. So which 1.5 would be the exceptions? Well, it would make sense that if they're the ones innervated by the ulnar nerve, they're probably the ones that are closest to the ulnar nerve. And since the ulnar nerve is on the medial side of the forearm, you'd expect it to be the 1.5 most medial muscles of the anterior forearm. So the most medial muscle of the anterior forearm is the flexor carpi ulnaris. So that's the one. And then the second most medial is the flexor digitorum profundus. But we only want half of that, so which half? The medial half, or the ulnar half. So the exceptions are the flexor carpi ulnaris and the medial or ulnar half of the flexor digitorum profundus. Those two will be ulnar, but everything else in the anterior forearm will be median. If we look at the hand is sort of just the opposite of the forearm. We said the forearm was mostly median, with the exception being ulnar. Well, for the hand, it's mostly ulnar, with the exceptions being median. So the hand, and remember, all muscles of the hand are anterior muscles. There are no posterior hand muscles. So all hand muscles are anterior. They all have to be innervated by anterior division nerves. Most of them are innervated by the ulnar nerve, but the exceptions are the median nerve. And again, we can approach it the same way. If there are going to be some muscles in the hand that are not innervated by the ulnar nerve, you'd expect them to be the ones that are furthest away from the ulnar nerve. In other words, the most lateral muscles in the hand. And if you look at the hand and say, what's the most lateral part of the hand? It's the thumb. So if we go back to the previous slide, we'll see that the most lateral muscles of the hand, 3 of them, are all together in the thenar compartment. So there are the 3 thenar muscles. That's one group of exceptions. three thenar muscles at the base of the thumb. And then the other group, there are two other muscles, the most lateral lumbricals, the lumbricals 1 and 2, or to say it another way, the lumbricals for digits 2 and 3. Remember, there are 4 lumbricals, but they go to digits 2, 3, 4, and 5. So lumbricals 1 and 2 go to digits 2 and 3. So these 3 plus these 2 are the 5 most lateral muscles, and therefore they're innervated by the median nerve. Everything else in the hand is innervated by the ulnar nerve. Everything else. Which includes, as a very important group, there are 7 muscles called the interosseous muscles, or the interossei, muscles between the metacarpals. And those interosseous muscles are the muscles responsible for abduction and adduction of the digits. It's not really important to remember which one's abduct and which one's adduct, because they're all innervated by the ulnar nerve, so it really doesn't matter. If you knock out the ulnar nerve, you knock out all of them. So don't worry about which are abductors and which are adductors. Okay, so we've finished all 3 anterior division nerves, and we've done all of the anterior muscles. So that just leaves us with 2 posterior division nerves, axillary and radial. The axillary nerve, we can deal with that pretty quickly. The axillary nerve only innervates 2 muscles, deltoid and teres minor, and only one of those is important to remember, because the teres minor, although it's true that the axillary nerve innervates it, because the teres minor doesn't do anything that other muscles don't do better. If you had a paralysis of the teres minor, it would be difficult to identify that in a patient, and therefore it's not likely that that would be a presenting symptom in a clinical vignette. So I wouldn't pay too much attention to the teres minor. The deltoid, on the other hand, is a very important muscle because it is the major abductor at the shoulder, so that's what we really need to remember. Axillary nerve innervates deltoid. Deltoid is a shoulder abductor. Okay, we're finished with the axillary. So that leaves us with just the radial nerve. We still haven't innervated any posterior compartment muscles for the posterior arm or posterior forearm. So all we have left is the radial, and so the radial does all of it. All of the posterior arm and all of the posterior forearm muscles are radial nerve. Remember that posterior muscles are primarily extensor muscles. So all extensor function, extension at the elbow, extension at the wrist, extension at the digital joints, all extensor function, radial nerve. Okay, all extensors are radial nerve. Okay, so that takes care of the radial nerve. So we've covered all 5 of the terminal nerves, and that's the information we need. What these 5 nerves innervate, that's the information we need to figure out what's happening when we have lesions of the terminal nerves. But what if the nerve lesion is not at this level? What if the lesion is at this level? What if it's a segmental lesion? A segmental lesion, a lesion of a spinal nerve or an anterior ramus, such as might occur in perhaps a herniated disc or something like that. Then we need to know how the muscles are innervated, not according to terminal nerve, but how they're innervated according to segmental innervation. In other words, is the muscle innervated by C5 or C6, or is it innervated by C7 or C8, or is it innervated by C8 or T1? Regardless of which terminal nerve is innervating it. So that's a whole separate way to learn muscle innervation, segmental innervation. But it's very easy because there's a very specific pattern to segmental innervation, and the pattern is described as having a proximal-distal gradient. Proximal-distal gradient. In other words, as we go out the limb from proximal to distal, the innervation to the muscles go from higher to lower. So the more proximal muscles will be innervated by the higher segments, C5 and C6. The distal muscles will be innervated by the lower segments, C8 and T1. In other words, all the muscles around the shoulder will be C5 and C6, regardless of which nerve is innervating them. Remember, these are all those collateral nerves, as well as the musculocutaneous. Those are the muscles around the shoulder. But regardless of which nerve is bringing the fibers to the muscle, it's all C5 and C6. The distal muscles, meaning the muscles in the hand, are all C8 and T1. Again, remember, some of them are median and some of them are ulnar, but they're all C8 and T1. Okay? So the proximo-distal gradient means shoulder muscles of C5 and C6. As we go out into the arm, it's C6 and C7. Go further into the forearm, it's C7 and C8. Go out to the hand, it's C8 and T1. Okay? All right. One other thing we want to know in order to analyze lesions is a little bit about cutaneous sensory innervation. And clinically, the only really important part of the upper limb for cutaneous sensation is the hand, because after all, that's what people use for feeling things, is the hand. And so you want to know the cutaneous sensory innervation of the hand. And that's summarized on this illustration. We see that the palmar side of the hand has two nerves involved, median nerve and ulnar nerve, with the boundary being the middle of the fourth digit. And on the dorsum of the hand, there are two nerves involved, radial and ulnar. Again, the middle of the fourth digit is the boundary. So that's the cutaneous innervation, but recognize that at a functional level, the only really important part of the hand for sensation is this, the palmar side of the first three digits. That's what people use for feeling things. That's where you hold things, right? And that's where you feel things, with your thumb and your index finger and your middle finger on the palmar side. So that means that the really important function of the median nerve is sensation. The most important functional loss that a patient has who has a median nerve injury is loss of sensation. So when you see a question about a median nerve injury, the first thing you should think about is hand sensation, or conversely, if one of the presenting symptoms in a clinical vignette is a patient with sensory loss in the hand, the first thing you should think about is median nerve, because that's certainly going to be presented as one of the chief complaints, because that's such an important function. So this region of the hand is what's really important, and that's median nerve.